Cummings Audiology, Section 2, Diagnostic Assessment, Chapter 134, Diagnostic Audiology and Electrophysiologic Assessment of Hearing. Tests to evaluate middle ear function. The term acoustic emittance is used to refer to either acoustic admittance, that is with which energy flows through a system, or acoustic impedance, total opposition to the flow of sound energy. Acoustic emittance measures are used clinically as both screening and diagnostic tools for the identification and classification of peripheral, particularly middle ear and central auditory disorders, and can be used as a tool to objectively estimate auditory sensitivity. The acoustic emittance measures used most often clinically include tympanometry and stapedial reflex measures. Tympanometry measures the acoustic emittance in the ear canal as a function of variations in air pressure in the ear canal. Testing includes placement of a probe onto the ear canal to form an airtight seal. The air pressure within the canal is then varied in both positive and negative directions relative to ambient pressure, while a probe tone is delivered to the ear. The amount of acoustic energy reflected from the eardrum is measured, which provides information about the transmission characteristics of the middle ear. The magnitude of the reflected acoustic energy changes as function of middle ear and eardrum status. The less compliant the system, the greater the intensity of reflected tone. In a normal ear, acoustic admittance is maximal near ambient pressure and decreases as the pressure in the ear canal is either decreased or increased relative to the ambient pressure. Specifically, tympanometry provides an estimation of intratympanic pressure, eustachian tube function, tympanic membrane integrity and mobility, and continuity of ossicular chain. Acoustic admittance is optimal when the same air pressure is presented on both sides of the tympanic membrane. Therefore, the peak of the tympanogram reflects the resting pressure in the middle ear. Because the eustachian tube serves to ventilate the middle ear space, the tympanogram peak also provides information regarding eustachian tube function. A negative tympanogram pressure peak almost variable. It indicates that the eustachian tube is not adequately ventilating the middle ear space because of eustachian tube obstruction caused by inflammation, infection, a mass lesion, or neuromuscular dysfunction. One of the most commonly used procedures to classify tympanogram shapes was first described by Leiden and later modified by Jagger and Maudlin and Jewett and Willinston. This classification of tympanogram shapes is described in figure 134.5. A type A pattern indicates normal middle ear pressure as indicated by a tympanogram peak at 0 dAPA. The two subcategories of type A patterns are type AD and type AS. The type AD shapes indicate an unusually high pressure peak and may be indicative of tympanic membrane or ossicular chain hypermobility caused by an atrophic tympanic membrane scar or an ossicular chain discontinuity. Type AS shapes indicates a pressure peak at zero, although the peak is reduced in amplitude. This reduction may be caused by the presence of ossicular chain fixation, which may be caused by autosclerotic stapes foot plate fixation. A type B pattern is flat, which indicates no point of maximum compliance and may be seen in cases of otitis media with effusion, space occupying lesions of the tympanic cavity, and tympanic membrane perforations. A type C pattern is indicative of negative middle ear pressure as reflected by a negative pressure peak and may be indicative of eustachian tube dysfunction. In addition, a type C tympanogram may be present in the early stages of otitis media without effusion. A type D pattern, which shows a notch in the pressure peak, is often seen with the scarred eardrums or with normal hypermobile eardrums. Acoustic emittance tools also provide information regarding the volume of air medial to the probe. This information, when used in conjunction with that derived from the evaluation of tympanogram's shape, can provide useful diagnostic data. In general, ear canal volume normally range from zero point 0.5 to 1 ml in children and zero point 0.6 to 2 ml in adults. Normal measurements greater than 2 ml in children and 2.5 ml in adults are usually indicative of tympanic membrane perforation or a patent pressure equalization tube because the volume measurement includes both the ear canal and the tympanic cavity. Stapedial reflex measures are also part of the middle ear test ear battery and provide important and useful diagnostic information. The two most commonly used stapedial reflex measures include the acoustic reflex threshold and acoustic reflex decay. Both of these tests measure changes in tympanic membrane compliance caused by contraction of the stapedius muscle and are particularly useful for differentiation of cochlear and retrocochlear lesion sites. The acoustic reflex threshold test determines the softest level of sound that will be elicit stapedial muscle contraction. This normally occurs bilaterally after either ipsilateral or contralateral stimulation when a pure tone or noise is presented to a normal hearing ear at levels of 70 to 100 decibel hearing loss. The neural network of the acoustic reflex is located in the lower brainstem. The contralateral acoustic reflex arc includes the acoustic nerve and ventral cochlear nucleus, the medial superior olive, the contralateral motor nucleus of cranial nerve 7, and the contralateral stapedius muscle. Any type of mid-ear disorder will prevent the tympanic membrane from showing a change in compliance when the stapedial muscle is contracted. Therefore, both ipsilateral and contralateral reflexes are absent bilaterally when the patient has a conductive hearing loss in the test ear. In cochlear pathologic tests, the acoustic reflex may occur when the impaired ear is stimulated at a level of 60 decibel or less, indicating the presence of loudness recruitment. However, as the cochlear loss increases to a greater than 60 decibel hearing loss, the chance of observing an acoustic reflex threshold decreases. In most cases of retrocochlear pathology, the acoustic reflexes are absent when the involved ear is stimulated. If acoustic reflexes are present, an ear with retrocochlear disease will frequently be unable to sustain contraction of the stapedius muscle as measured with the acoustic reflex decay test. Lastly, the absence of contralateral reflexes with ipsilateral reflexes intact may be seen in patients with brainstem disease as a result of the presence of a lesion in the area of the cross brainstem pathways. The stapedius reflex also provides valuable clinical information regarding the level of facial nerve lesion in patients with facial nerve paralysis. If the lesion is proximal, an absent stapedial reflex may be expected. If the lesion is distal to the stapedial branch, an intact reflex may be expected. Stapedius reflex measurement should be included routinely in the evaluation of patients with facial nerve paralysis. Acoustic reflex decay measures the ability of the stapedius muscle to maintain sustained contraction. During this test, a signal is presented 10 decibel above the acoustic reflex threshold for 10 seconds. A response is considered abnormal if the response amplitude decreases to one half or less of its original amplitude within 5 seconds. Because reflex decay is common in many normal ears at higher test frequencies of 500 and 1000 Hz are most often used in acoustic reflex decay tests. Abnormal reflex decay may be indicative of retrocochlear disease. Those with a cochlear or conductive hearing loss will show negative acoustic reflex decay when an acoustic reflex threshold is present in the test ear. Thank you.